Hello, and thank you for all joining us on our latest installment of the series Visual DX Academy Master Educational Program. My name is Dr. Art Papier. I'm the CEO and co-founder of Visual DX. We're thrilled to bring to you an important conversation on dermatologic photography with a wonderful panel of experts. I want to begin by thanking our sponsor, Janssen Pharmaceuticals, for supporting this effort. Before I introduce our panel, I'd like to discuss a few things. This presentation is being recorded and will be shared to all registrants. We've allotted time today for questions. Within your screen, you should see the Q&A tab, and feel free to enter your questions throughout the panel presentation and discussion. Along the top of your window, you'll see also we have an educational supplement for you to download. After the Q&A, we'll be testing your knowledge with a Kahoot quiz where there will be a prize, so you'll all want to stick around for that. Okay, so without further ado, let's introduce the panel. First, Dr. Jeff Callen is professor as well as chief of the Division of Dermatology at the University of Louisville. Dr. Callen has been a long-standing image contributor to Visual DX, and we are also proud to announce Dr. Callen is our new Visual DX image case section editor. Along with Dr. Callen, we have Dr. Sonya Burton, who's also an active image contributor to Visual DX. She's assistant clinical professor of dermatology at George Washington Medical Faculty Associates. Dr. Kenneth Greer is a professor of dermatology at University of Virginia with clinical interests in general medical and surgical dermatology and a renowned dermatologic photographer. As well, we have Dr. Ilona Frieden, pediatric dermatologist, professor of dermatology at UCSF, and also a maven of medical photography and Kodachromes. Thank you all for taking the time to discuss dermatologic photography. Dr. Callen, I'll let you take over.
Okay, thanks, Art. Thanks for putting this together and allowing us to speak about a subject that I think we all have a major interest in, kind of love. I think we agreed earlier as we were discussing among our panelists that maybe we would introduce ourselves and tell you a little bit about how we got interested in photography. So I'll kick it off and let Ilona start. Ilona, you want to tell us what piqued your interest?
So I kind of look back and I think I probably this was imprinted on me by people when I started dermatology. I had a professor named John Reeves who was a really good photographer, and he always carried his camera around with him. And then when I began to work with Nancy Esterly, who was a major contributor to Visual DX, she was a wonderful photographer and always carried her like one or more cameras around. And I just kind of came into dermatology thinking that was normal. That was just what you did if you really cared about teaching and about being able to see patients. And I took that through with me for the last almost 40 years of my career. Actually, it's been more than 40, including my residency. And I love photography. I feel like it's so important, but I also feel that this is kind of to quote Dickens, it's kind of the best of times, the worst of times. Photographs are so much more easily available because we all have portable phones that can directly link to our medical records. But the worst of times, because sometimes the equipment is not good and sometimes we can't get to the metadata. And I built my career on looking back at photographs now. Those are in places that I can't easily retrieve as I used to be able to.
Sonya, you want to tell us about your interest and how you got started? And
I just got started on my own. In residency, we had a film camera, which, you know, of course, you would take a picture and not know how it was going to turn out, and you just hoped that the photo of the interesting case actually turned out. By the time the film was developed, the patient, of course, was long gone, and perhaps their skin condition might have resolved. So, you know, it was, but I always felt like it was hit or miss. You know, I didn't really know what I was doing, basically. So fast forward a few years, and, you know, digital photography came along, and I was pretty skeptical at first, you know, that was going to be as good as, you know, film photography. And, you know, then when I went to one of our national meetings, I stopped at a booth of a company that sells photographic equipment, and I was just really impressed at the results. And so I said, let me just try this on my own. And I honestly, it's just an interest that has been self-motivated. The first, I don't know, several months or year, my, pictures weren't necessarily very good, but I just practiced and practiced and practiced. And then I just feel like I got a feel for it. So it's just something I like to do. If they're, pictures are great for teaching residents, or just for my own, personal learning. So just over the years, I just accumulated, many, many, many pictures, not necessarily having a specific goal in mind, but it was just something I enjoyed doing.
Kenny, how about you?
Well, I got interested in the photographing of skin disease in 1971 when I started my residency. And there was a stimulus because if you took 7 photographs, you got to keep one. These are all Kodachromes, of course, for the first 40 years. And every resident, there were 6 residents, got a copy and one for the department. And I had no idea I was going to end up in academic dermatology, but I started my collection early. And I must admit, in the beginning, I really needed some help in background on how to take photographs. But over the years, I changed the way that I did backgrounds and paraphernalia inside in the pictures. And so I accumulated a large number of them. And just recently, we've been digitalizing, or up to 50,000 of my slides. But I use them for teaching, and that's, as Jeff knows, as many lectures he's given around the country. And he used to go around carrying about 8 carousels in a great big unit. Now it's simpler, but we would take our carousels and did little boxes of film and give different lectures at meetings. And I wouldn't trade it. And I think that Kodachrome served us fantastically. As Dr. Burton mentioned, you didn't know what you were getting back, and you didn't know if your lighting was right or what until Kodak processed it. And so that was a downside. Now you can look and see. I do think that the lighting and the side lights and the ring lights we did were really superb. And I'm afraid that most places are not shooting with fancy cameras, just doing them off the phone with no flash and stuff. But that's my background.
Yeah, so my background goes, let's say, probably goes back into the time when I was a kid, because my father was sort of an amateur photographer. He was a cardiologist. He wasn't doing any medical photography, but he got me excited about taking pictures. We actually had a dark room in our home, and I would go and particularly at football games, like to go to the Bears games in Chicago, and I would take photographs and then come home and we'd develop them. And then when I was in medical school, I was still taking pictures, and there was a friend across the way that had a dark room, did a lot of black and white there, but at my house, I did color developing. And then as soon as I got into dermatology, I had whole bunches of cameras from my dad. And it was like, we had a camera in the clinic, but the camera I had, I thought was better, and I carried it wherever I went. If I went up to the, to see a consult on the floor at the University of Michigan, I took my camera with me. And then it's like, and then my collection was like, it was good, but I met Ken Greer, I met Lauren Golitz, I met, let's see, who else was I? Neil Fensky, Fernando Botero. I met these guys, and it was like we were like kids trading stamps or trading cards and stuff like that, because I'd take a picture for me, picture for the chart, picture for Greer, one for Golitz, one for, and then I'd dole them out. When I filled up a box, I'd send them off to Kenny, or I'd send them off to Lauren, and then they'd send me a group of their pictures, and it was just a great time. Anyway, tonight, with that introduction, tonight what we're going to do briefly, hopefully in the next maybe 15, 20 minutes, is to run through some PowerPoint presentation, and we're going to talk about why images are important. The images taken during a patient examination can be useful in discussions with our dermatologist. That's one thing. They can assist us in identifying the correct site. Our colleagues in dermatologic surgery really have been hampered in the past when images weren't readily available. Now, when you can put an image in the chart, and if that's the purpose, then the image is only to tell you where something was. There are medical legal issues that relate to capturing images, which are sometimes good and sometimes bad. Medical education, as Dr. Greer has already alluded to, is something that the four of us on this panel have been involved with for a long period of time. And the best way to educate, what do they say? A picture's worth 1,000 words. And so having images allows you to educate your colleagues, our non-dermatologic colleagues, our patients, and then of course they're useful for publications. So what's the perspective from the patients? That's come up. It's interesting. That has come up recently in a lot of literature, particularly in the last since Obamacare passed, when the high-tech and HIPAA issues became more important. So there are a number of studies which have looked at the patient perspectives about medical photography. One of them is referenced at the bottom of the slide that you can see you can see it in pretty small print, but how do patients perceive what the images are for? Well, I think the thing that you have to do is, in my opinion, is you have to make a patient feel comfortable with why you are obtaining the photographs and telling them that I use them to teach. I'm going to use your photographs in this particular way. Now, interestingly, in this study that we're referencing here, people's perception of and willingness to allow the photographs to be taken varies, and it's influenced by by what you're taking a picture of, what the use is going to be, what their gender is, what their socioeconomic status is, their age, and their race. And there are people who they differ and have shown to be different. So most patients in these studies, this is, I think, let's see, this one is maybe it's a different study that we're referencing at the bottom, but most patients in the studies have felt that medical images could improve their medical care in the clinical setting. They have found that smartphones are acceptable as long as you're talking to them about that you're using it and telling them where their photographs might become available. We'll talk a little bit more about smartphones because there are definite issues with using your smartphone, whether it's going directly into the chart, and then what type of compression the phone has, and whether the image is then later useful for, say, publication when you're using it in a smartphone type setting. But most patients, I think, I find, and hopefully others on the panel can weigh in as well, I have hardly found anyone who is, I'd say maybe 1 or 2 out of 100 patients that I ask if I can take a picture will tell me no, that they really don't want me to take a picture. And I say, okay, no problem. And we don't take it. And then how do you consent patients? For years and years and years, oral consent is what we've been doing. If you are in a VA, there's no question you are not going to just do oral consent, and you're not going to take things on your unless you're going to if you're abiding by the rules of the Veterans Administration and they see you taking a picture on your smartphone or your iPad, they're going to try and confiscate your device. If they see you taking it with a personal camera, they're going to try to confiscate that. But other than that, in office settings, depending on what office you're in, a written consent may be available, a written consent may not, but oral consent has been acceptable in most instances now, and publications vary depending on what's being shown. There are racial disparities like everywhere else, but patients who are, and whether this is the appropriate term, It is what what was used in this article. If they're Hispanic, African American, Afro-Caribbean, they have that those groups in general have been less accepting of medical photography than people from Asian countries or people who are considered Caucasian. And they, but when explained, again, the same thing, when explained, most patients will not refuse, me anyway. Others on the panel can tell me how they see it or how they've felt about it. Anyway, skin, we're going to come in a little bit later. Dr. Burton specifically is going to talk about some issues that relate to skin of color and how you might adjust your cameras when you're taking pictures. Because as there was a recent article that Dr. Greer was co-author of, which was in JAMA Dermatology about maybe a week or 10 days ago. And he talked, they were talking about Kodachromes. We use that term loosely because when we have a Kodachrome session, we all know that we're showing images, and that it isn't really, we don't have any Kodachromes anymore. Kodachromes haven't existed since, I can't remember, is it 2001 or 1991 or something like that, but they disappeared. Kodak doesn't make Kodachromes anymore, but we still use it. We call it a Kodachrome session, and even if it wasn't Kodachrome, if it was Ektachrome or Fujichrome or Agfachrome, we would still call it a Kodachrome session. And as Dr. Greer alluded to, he and I were part of putting together a couple of atlases. And when we first met back in the day in Philadelphia at the publishing company, I had this, my hands aren't set at a there was way out there. I had a carousel holder that held 8 or 10 carousels. So, and each carousel had 80 slides. So I had about 800 to 1,000 slides, and we looked through those to pick out the best slides. And then somebody would unload the carousel and somebody else would load the next one in, because we had thousands of pictures that we were dealing with. So how about ethical issues? Well, Jane Grankel's, who likes to talk about ethical issues, was part of this article, which was kind of interesting. It's just like anything else that you're doing in a procedural. This is a procedure essentially. It is not invasive. You're not hurting the patient in any way, but you need to tell the patient what the use is. And if they want to refuse, why, that they're not going to lose their health care because they do that. And then, sharing images. If I think when I have an inkling that I might be sharing it, I ask the patient, I say, look, it's not HIPAA compliant for me to share it with some colleagues, but I want to get some consults. I want to ask some people that aren't in Louisville, that aren't in my office, about your skin disease. Do you mind if I share these photos? And I have yet to find somebody who, when I explained it that way, who wouldn't say, yes, I have no problem with that. In this article that is referenced there, they have two demonstrations of two examples as part of the article of consents that you might use in your office. And then in it, they also talked about the storage method, the security of the storage. And it's critical that the patient really understands how they're going to be used, and that their name is not going to be attached in some way that somebody can then find out and do something. I mean, I never had anybody who had anything happen to their images. So in the outpatient setting, I think you do have to ask yourself, what is the reason that what's the intent? What's the reason that you're capturing images? Is it because you want to talk to other physicians about them? Do you want your dermatopathologist to see the image and to be involved in that clinical pathologic correlation? Dermatology residents use the images for educational purposes. They use them for publication. It's ideal, as we've already said in the past slide, to have a written consent, but verbal consent can be obtained, and particularly if the image is not identifiable by someone else other than the patient or their immediate family members. Now, what you don't want to, if you have a patient who has a tattoo, those are identifiable. If you're taking a full facial image of a patient, that's identifiable. And so then you should have a written consent for certain. Putting a label on all your images makes the image identifiable. And I had to argue with people at our VA about whether or not we could take a picture first without a label and then take a picture with a label that we would then put into the chart. They insisted on having labels at some point in time. Eventually, they did allow us to take our pictures as long as we had consented the patient appropriately. And so I gave a talk to the administrative people at the VA, because they said, you can identify images, you can, and these are all, let's see, this is a patient who was a patient at the VA. I dare you to say who any of these people are, and identify them. Unless you saw them live, you wouldn't, I don't think you would know. And then which of these pictures are a man? There are 2 men and 2 women, but I don't know that you would know who they necessarily are. And if you're taking pictures, it's better to take rings off, like there's a ring here and there's a ring here. This is a patient who has herpes zoster. This is a patient with tinea incognito. This is a patient with connective tissue disease. And this is another patient with connective tissue disease. So I gave this presentation to the VA, and then the VA backed off a little bit. What identifies this person? I mean, I suppose if we had one of those iris scans, we could identify the patient, but we were using it to capture this particular hydrocystoma that's there. And then, of course, he has these milia, but and then if I was using this image, if we really wanted to get technical, and I don't know, maybe Art will, I'll send this on to Visual DX at some point. But when we do, we'll probably crop it so that we get rid of the area that's his nose, and that's out of the focal plane. And so this is very sharp and clearly sharply demonstrates in focus, but this is not. So we would crop it. Can you identify who this patient is that has vasculitis? So what are the qualities of a good image? Well, we're going to talk a little bit about lighting, about exposure, background. And I think that's Dr. Ken Greer already talked a little bit about how he moved to certain backgrounds. Lenses and zoom, I think Dr. Burton's going to talk a little bit about that. Focus. Please, if you're going to take an image, take the time to think about all of these things, but make sure that your image is in focus. Now with smartphones, you can tap on the screen and it focuses for you. With a 35 millimeter single lens reflex camera, you can see the image and you can see if it's in focus. Ones that aren't in focus, don't put them in a chart, discard them, take another picture. Take time to do that. What you don't want to do is you don't want to go to a conference and say, well, I got this really bad picture. I'm sorry about it. You don't want to apologize for your pictures. Take the time to take a good picture. And then, set the standard for disease documentation and the composition. We'll talk a little bit about that in a moment. So these images, this one's with natural light, this one's with flash photography, and this one is with room light. Apparently they're all taken with a similar background. You can see that there's differences between the background, the shadowing. I personally like this one on the right. Others may vary. Anybody who wants to chime in, please chime in. I'm not opposed to people saying, but the lighting, think about the lighting. Some of your cameras, the flash will be automatically come in. The natural light, the problem with that on the left is that it's destroying the image. You're seeing too much, there's too much light there that's coming into the image. Not as much on the flash because it highlights things, and the room, just natural room light without having light from outside the room is I think that's the best. Okay, overexposed, underexposed. Again, you can take a look at, if you're using a single lens reflex camera, you can see it on the back of the camera with these digital cameras. If you're using a smartphone, you can open up the picture and see what it looks like, see if it's in focus, see if it's exposed properly. Okay, the background. It's, this is what the patient was wearing. So somebody took a picture of her. The problem is that your focus, the eye ends up focusing on the background. So that's not good. I don't mind a blue background, but if you look at this carefully, you'll see that the blue has melded. This is a, contact dermatitis. The blue has come into the image up on the top. It hasn't come in the bottom, but you can see it sort of changing the coloration of the skin. And then I've always been prone to using a black background, as you see on the right. For skin of color, that may be different, and Sonya will tell us a little bit about that. Now, with smartphones, what they tell us is move a little bit away from the patient, further away with the smartphone, and then zoom in so that you get the image and the basically by doing that, it focuses it, and it's sharper when you have that happen. So in focus here on the right, same out of focus. If you take a picture like this on the right, discard it. Don't put in the chart. The only reason to put it, if you take an out of focus picture, the only value is to show where a biopsy had been done. And in that case, if that's the only picture you have, okay, put it in the chart because you want the surgeon to cut out the right area. But otherwise, get rid of it. Don't keep it. Don't put things in the chart that don't belong. Okay, so the composition. This is from an article that was written in 1962. It was published in The Lancet. And so, and it relates to the cameras that we used to use that were single lens reflex, where we were taking with Kodachrome or whatever other film you were using. But the center of interest, these are all sort of these are depictions of what was in that article because we can't use the actual ones that were in the article. So it's more interesting if you center the image on what you're trying to focus on. And the composition, having an arm go across the screen versus having it go straight across, it makes it a little more interesting. Having a nail, and why take the picture like this, where it's further away, you don't really see where the pathology might be, doesn't fill the screen. It would be even better if you didn't have this dead space here. And then I'm particular. I mean, the hands, when you're seeing them naturally, when you're examining the patient, they are down, and they're not up like this. They're not showing you. I mean, if you want to demonstrate something that is that way, you can. When you take a picture of dermatitis herpetiformis and you're trying to take the elbows, of course you want to take it that way. But if you're taking a picture of the hands or the feet, take it as though you were seeing the patient and store it that way. Don't take it upside down like this. Okay.
Could I make a comment here, Jeff, about that?
Yeah, go ahead.
I mean, these things sound obvious when you say them, and yet these are the most common mistakes that get made. I kind of am a little more forgiving, to be honest, for background issues, because it takes time. You have to have the right setup. And if you don't, you just have to deal with doing the best you can with backgrounds. But to take things at an oblique angle or not center them is really, it's like not doing a shave biopsy correctly. It's like you need, this is part of what you do to be a good dermatologist. And I would argue that very strongly, that I really liked what Sonya said about you learn from the pictures. Like you go back and you see things on the pictures that you didn't even pick up when the patient was there in person. So the more photography you're doing, the more you will learn. And these are just basic principles that you want to try and internalize, because over time, it just makes things so much better for you and for the patient.
Thanks. So now the other thing is, if you are taking the picture for the purpose of identifying where the lesion was, because you're going to have someone remove that lesion at some time in the future, you want to do what is on the left. And that is to take the picture so that there is some landmark. You can see that this is on the face. We can see the same lesion. This is a close-up of it. But for the purpose of you can see where his earlobe is. And you could then sort of get the idea of where this is in relationship, because patients forget. And it may be a month before they get into the dermatologic surgeon. They don't have a clue as to where that biopsy was that they need, that needs to be treated. And you don't want to have wrong site surgery. Okay, so this one, I have this one, this image, and then the next image. Both of them are things that are on the chest. Here's a patient, I think, that has, it's a patient of mine, and we diagnosed erythema annulare centrifugum here. The next one is a patient who has lichen sclerosis morphea overlap. Now, between these two pictures, the better one is the second one. I mean, they're both good pictures. But when you project these, look at all the dead space on the side of the screen, whereas this picture fills up the screen. There's much less dead space. And in fact, if the people at Visual DX hadn't made it smaller, it would fill up the whole screen. And that's best to do. You don't want to have all this dead space when you're showing. You want to show them that you want to have as big a picture as you can. Okay. So this again is the composition. So you want an image like this, but not oriented crazy like that. I mean, there's sometimes when you can't help yourself, and when a patient is in a bed, if they're standing, you don't want the camera down here looking up. Well, the same is true. If they're laying in a bed, you want to position yourself or the camera in such a way that it is perpendicular to the body or to the body part that you're that you're trying to capture. This way, you get areas that are in focus and out of focus. Okay. Now, there's a different sort of standard for taking images of things that you want to, like when you're mole mapping. So here you want to have a faraway image, you want to have maybe a medium image, and you certainly want to have a close-up image on certain lesions. But it's for a different purpose. It's for documentation, not necessarily for presentation. When you're taking hundreds of pictures of a patient who has atypical moles. Sonya, you want to take over? You just have to say next when you want me to change it, because I have control of the screen.
Sure. You can go to the next slide. Okay, let's see. So there are some challenges for photographing skin of color. One of the most common ones that I have found is that with the use of the built-in flash, you often get this prominent reflection of light off of the surface of the skin. It directly reflects back into the lens, which causes glare that obscures detail. I find that this occurs more commonly on convex surfaces, which probably just reflects the fact that that's the most, or that's the surface that's closest to the lens. So to try to prevent that from happening, now in theory, you can take your pictures using natural light, but of course that's not always going to be practical, especially if you're in an exam room where there's no windows. So it's an idea in theory, but it doesn't always work in practice. You could also try to position the light source, or the flash source, I should say, excuse me, at an angle. You can do that in one of two ways. One is you can consider using an external flash unit that attaches to the top of the camera that allows you to to change the angle of the flash. Another way that you can do that, which isn't on the slide, is you can very slightly change your orientation so that you're at a very slight angle to the subject. That doesn't always lend itself to every subject, because in general, you want to take the picture, pretty much, at a angle that's perpendicular to the subject. So it doesn't always work, but you can try it. All right, next picture. So there are a number of articles that have been written on, dermatologic photography that state, that white and gray backgrounds are good choices for photographing skin of color because they provide greater contrast and reflect more light onto the subject than black backgrounds. All right, next. In my experience, if you're giving attention to lighting and exposure, you can photograph skin of color against black backgrounds, and it can result in high quality images. So I have found a way to make it work for me. So it is possible. Maybe that works. Maybe it's not. Maybe it doesn't work as well with smartphones. I don't use one, so I can't comment on that. If anybody has any experience, they can feel free to give their opinion on that. But I use a digital SLR camera, and I get it to work just fine with the black background. And I like the black background also because you don't get those shadows that you often will get on a light background. So, all right, next.
Can I make a comment about that?
Sure.
Just, and I think this is because we exclusively use smartphone technology for taking photos, because if a camera accidentally gets stolen with the photographs in it, that's like a huge issue for our medical center, and every single person who might or might not have a photograph on that camera has to get notified, and as a HIPAA violation, potentially loss of PHI. So for several years now, we just use a smartphone technology going directly into the medical record. But one thing that you can do is, and you should do, is always to look after you take the photograph. I think Jeff alluded to this. And look at it compared to the picture, the patient themselves who's sitting right in front of you. Does it look like the patient? Is the color the same? Is it different? Sometimes that will mandate actually using flash, which is not I would say that's the exception rather than the rule. But looking for color match is really important, I think, in terms of trying to decide whether it accurately reflects the patient. And you should be doing that in real time. And that, I think, is also helpful.
Yeah, so what we did, Ilona, what I do, let me put it that way, is I have an SLR in the clinic. So I took pictures of maybe 4 or 5 patients today. I immediately go and load them into the chart and erase it from the disk that's on the camera. And that way, somebody steals the camera, they've just stolen the camera, they haven't stolen the disk. Didn't used to do that, but because of all the bad press that occurred when somebody's car was broken into because they had their camera hanging around in the car, it becomes a nightmare to try to notify all these patients. Sonya, you want to go ahead?
Sure. Excuse me. So this was a picture of a woman with lichen planus that had Fitzpatrick skin type 4, again, against a black background. And I thought it turned out pretty well. Also, when I take pictures in clinic, in practice, I'm taking multiple shots at slightly different exposures, because it's sometimes difficult to tell, by looking through the LCD, the image on the LCD screen, which one is, the best image. So I tend to, take a picture at a certain exposure, then I'll change it slightly, take another picture, change it slightly again, take another picture. And oftentimes I really don't get a sense of what the best image is until I upload those pictures onto my computer. So, the rule of thumb is never delete any pictures until you put them on your computer, because you really can't always tell I mean, maybe, you know, excluding the outliers that are just really, really, really bad pictures, but that's just something I've learned the hard way. You just never delete any until you review it. All right, next picture. And this is another picture that I took of a patient with Fitzpatrick skin type 4, or excuse me, probably 5, excuse me. This was not a case that I ever submitted to Visual DX because we never really figured out exactly what this was, but the picture is good. We think it's a chemical leukoderma, but there was some we had some difficulty figuring out exactly what it was, and it wasn't hair dye. That wasn't the cause either. But I like the picture. So, all right, next. So, and I alluded to this a little bit already. So, you know, what type of camera to use, smartphone versus digital SLR camera. Again, I don't use a smartphone. Of course, some people do. The advantages of smartphones is that, you know, they're light and easily portable. Many models are relatively inexpensive. They're simple to use, and almost everyone already owns one. Disadvantages are that the image quality is lower. There's less control over exposure and other settings, and they're less versatile because there are a limited number of lenses. In contrast to digital SLR camera advantages, there's a higher image quality, greater control over exposure and other settings, and they are more versatile because they can be used with a greater number of interchangeable lenses. And the disadvantages are that they are larger, heavier, and bulkier. There's an expense involved in purchasing one, as well as the lens. And then there's a learning curve involved. And by the way, I use a macro lens for all of my photography, which allows you to really, you know, focus. It allows you to perform extremely close-up photography, which is useful for photographing small lesions such as papules. All right, next.
Okay, so I think it's back to me now. If you're taking the time to take a photograph of a patient, consider what the use is. Take the best photo possible. Take the largest master image to afford the most flexibility for future use. Again, this one's a picture of mine. This is a patient who has we called it, let's see, this is one of those mashup words. It's a patient who has lupus erythematosus, and he had these lesions, and we called it the lupus erythematosus geratum repens. But that's what it is. Anyway, that's the end of our formal presentation. I'm going to leave this up. Let's see, am I going to leave this? This is Art to talk about. I'm going to leave that slide up. And Art, we can, I can either advance to that, or you can tell us what questions people have, or anybody on the panel who has something else to say, please add it in now.
Well, first of all, thanks for the presentation. There is at least one question in the chat so far, and it was hard for me not to go off the hide and just pipe in. There's so many interesting questions around why have we had a voltage drop from when we were film-based to being digital. It's a paradox in my mind. I think our collections and our departments for teaching education, research were better on film than they are in digital. And you know, the trade-off is really expediency and speed against quality. And I'm just wondering if any reflections from this panel, because we all have lived through this transition from film-based photography to digital. And it's, in my opinion, it's really destroyed the department teaching collection. So it's something we're very, very interested in Visual DX, but I'd like to hear from the panel on this.
I'll just speak up. I agree with you 100% that the quality could be made unbelievably well, even if you had to wait a week to get your box of slides back from Kodak. But we do digitals now and we use them in PowerPoints left and right. But I don't see the detail work that we had to do when we did film. We had to really know. We had to be sharp. I ran through so many side lights, Honeywell, you know, flashes and ring flashes and everything. We don't really have to do that so much now, these cameras. But I'm prejudiced towards the Kodachrome, that general term that Jeff mentioned, but I still call them Kodachromes and like them better.
There are a few questions in the chat now. Let me start with the first one, which is what about blue background? So I think there are different opinions on gray versus blue versus black. And there's different preferences, I think, what I'm hearing. What does the group think is, do we have agreement in this panel what the ideal color is universally?
Okay, ideal is in the minds, in the eyes of the beholder, Art. It's like when Kenny and I and others were working on the atlas that we put together. Amy Paller was part of that, and Amy had taken over Nan Esterly's position at Northwestern Children's in Chicago, and Amy was a blue background person. I was a black background person. And then as Dr. Burton mentioned, some people think that the gray or a lighter background is good in patients of color, but it's what do you like looking at? And the only problem with the blue background depends on the blue, and it depends on a deeper blue, I think, is better. But you get that bleeding into the actual image. Is that really disturbing? Does it take away from the fact, the image we showed was a patient with poison ivy. Does it take away from the ability of us to educate and to know what that disease was? Probably not. So, it becomes very, very subjective. Anyone else?
Well, I use a relatively light green background, like a surgical gown, surgical sheet, because I had access to it. And if you got a little child might urinate on it, and you got it, if you only got one black background, you're going to have to wait for a while or whatever it was. So I have a green background. When Jeff and I,
that's a really important point, is like your background becoming a fomite and having, clean background. So sometimes a surgical chuck, or that could be white or blue, any background that's solid is better than that plaid shirt that you showed in the picture. So I think just having a background would be a big improvement. Let me move on to another question. What are some special considerations you take with photographing pediatric patients?
Ilona, you want to take that?
Sure. I think that, first of all, it's interesting. A lot of children are used to being photographed all the time now by their parents because, like I'm a grandparent now, and I get text messages multiple times a day with pictures of my grandkids. It's just ubiquitous in their lives. And sometimes they feel more comfortable with having a photograph taken than they do even being examined. So I find that it's not a foreign object to a child. So a child that's fearful will often be more willing to hold still for you for a photograph than they will for you to examine them. Now, of course, with infants, it's a matter of preparing yourself and trying to take enough photos that you can get things in focus if they're moving all the time. And some tips for that are having them in a position of comfort, which means sitting in their parent's lap. I would tend to much rather do that than have them lying on an exam table, even if an exam table might give me kind of a better view in a way. So those are some tips. I also want to say, in terms of, as I've already said, I'm stuck with digital photography, and I agree it's not as beautiful as the photographs that I used to take. I will freely admit that. On the other hand, the upside of it is I'm much more able to do things like follow vitiligo responses or hemangioma responses to therapy in real time, each time I see the patient, than I ever could with the Kodachromes that I took, because they cost money. This doesn't cost me anything. And we've actually done studies where we've looked at parental photographs to look at natural history of disease. We get photographs of viral exanthems that we see on day one, which we never used to get because we didn't see patients with viral exanthems the first day. And so we use those to diagnose things that have evolved. So I think there's a huge upside to the current environment that we're in. And I use those and we're getting lots of parents' photographs. So to the point of the parents taking photographs, there are two key points I'd like to make for patient photographs. Don't give me just a close-up. Give me a medium view and give me then something a little bit closer, because the mistake of parents is to send in that incredible close-up and you have no idea where on the body you are. You don't know what the context is, etc. And I think that we can come up with some best practices. We should come up with best practices for patients sending us photographs too, which is a daily part of our practice.
A couple more questions in the chat I want to get to is one is, what type of consents do you use in clinic? Do you consent everyone that comes in and then ask verbally? And I'll tell you what we do at University of Rochester is we consent everyone and then we verbally consent them as well. So I think, Jeff, you mentioned the VA. I think more and more centers really want to button this down. And it's really an easy thing to do when they check in to have them sign the consent. But then ethically, I think you really should explain, as you pointed out, Jeff, how you're using the photographs. Other thoughts on consent?
Yeah, so I'm in an unusual situation. I have a private practice and I'm part of, and in that private practice, if I do a verbal consent for everyone. If I'm taking an image that is going to be used, if it's an image of a kid, I will have the patient, have the mother or father sign the consent. But otherwise, I only have a written consent when we're taking an image that is something that will be recognizable at some later date. That's probably, if you're in a medical center, that is not acceptable. In most medical centers, it's not acceptable at the VA. And it depends on the practice. If you're with a big group and they say you need to consent, well, do it. I mean, the electronic record, it does make it really pretty easy to consent. And I ask the patient if they want a copy of the consent that they just signed. And I would say that 99% of the people don't want another piece of paper. They're going to throw it away anyway. And they say, no, I don't need that paper. But we always offer it to them. Kenny, what are you doing?
One more quick question. Do the speakers have any tips for dermascopic photography?
I have recently gotten the adapter for my iPhone to connect to the 3Gen, and it's a little tricky to use, but I'm practicing with it, and I think it's a good way. I've been told that the iPhone 13, that you actually can get close to a dermatoscopic level of detail by zooming, but I have an iPhone 12, so I can't really personally comment on that.
Yeah,
I think there's some really good adapters.
Yeah, I've used an adapter and it's okay. I personally don't take a lot of dermatoscopic images, but that's me.
Okay, well, this was a great Q&A, great panel. We're going to do a few fun things. First, we're going to move to this Kahoot quiz. It's going to have some questions on dermatologic photography, and then we have a few announcements that are kind of fun. So let's move ahead to Kahoot. Hopefully the participants in the webinar have downloaded the app. You type in the pin on the screen or you put it into your browser on your internet. We'll see if people are going to play the quiz tonight. While we're waiting, my favorite topic is really excellence in photography. And one thing that we didn't really discuss is the variation in presentation and what type of photographs do you take for education? And, we're taking photographs in Epic through the Epic app, but we're taking those usually for patient care. So how do we make decisions about what to photograph for education? How do you think about that when you decide what's worthy of getting out the SLR? What's worthy of taking a picture outside of haiku and Epic? Yeah,
so for me, what's worthy of getting out the single lens reflex, which is in my possession in the clinic that I'm working in, is when I think it's something that's a slight bit unusual that I'm going to present at one of our conferences, because for our medical record, which is, let's see, what's it called? Modernizing Medicine is what we use in our private practice. You can take a picture from your phone or from your iPad. But the problem with that is that the iPad photos, when they go in, are like compressed. And so they're okay for showing at a conference, but they are not okay for publication. So if I have any inkling that there's something unusual, I'm going to pull out the single lens reflex. Now, if you take them with your smartphone and then transfer that into the chart, those have pretty good resolutions these days. They're not micronized, and but it's sometimes I'll take a picture with the iPhone and then one with the single lens reflex, and sometimes you can't tell the difference if the resolution of the photo is good.
And I'm going to hand it off to Kim, who's going to run the Kahoot, or Melissa, and I think we'll get going with that.
Okay, great. Looks like we're just going to get started here. And good luck, everyone. You'll need to look at your mobile device to put your answer in once you see this question appear in front of you on the screen. There will be a prize for the winner, so best of luck. Great job. Wow, looks like we stumped some of you. Fantastic.
I would say that they're all right answers. That's a terrible photograph. Throw it out.
I would agree 100%. There's no answer. Everybody gets credit for that one then.
Great job to those of you that got that one right.
Yeah, isn't that interesting?
It is interesting.
Yeah, because I think the majority of people did not answer what I would consider the right answer. It's the tattoo.
The prize on the line. These are challenging questions.
Now we will see if they were listening, Jeff.
Yeah, exactly.
Or how well they were listening.
Yeah.
Wow, fantastic.
But there are two wrong, there were two correct answers.
There was one that was, I think, the best correct
Oh, I
answer.
see, that's true.
We have 2 questions left. We have some players with a 3-question streak. Congratulations. Okay, and our final question before we get to the leaderboard. Fantastic, congratulations.
While they're tallying up, Art, I'm gonna say I've got 100 boxes of Kodachrome left in my collection.
Your secret stash when it comes back like vinyl.
I'm saving.
It's just like the vinyl. You'll be able to get your Kodachromes developed.
I pass them around in the new residents to see if they know what this is.
Oh no, I asked, yeah, one day I asked the staff
So
if they ever heard of it.
congratulations to CL. Whoever
Yeah.
CL is, we'll be emailing CL a gift, and we really appreciate people participating in the Kahoot quiz. We'll move on to and there's a few more slides to wrap it up very quickly. If we can put the slides up. We have an image community. We have wonderful contributors, like many of the experts on the panel tonight. We get images from around the world. We truly love medical photography and capturing the variation in medical images and the presentation of our patients. And our mission is not just dermatology. We have oral mucosal images, eye images, medical images of all type. We're really committed to building what we argue is already the world's best professional medical image collection. And our mission really is to improve patient care, improve education. We get tons of stories from users about how these images are used in the exam room to teach patients. Over and over again, we hear how important it is to show a contextual image to a patient. If you have a patient of color, show them what zoster looks like in skin of color, not in a white image. And this is some real value to medical photography in our view. And we'd love to have anybody who's listening join our team. And as I mentioned at the beginning, Jeff is our new image section editor. So please email us at images@visualdx.com. We also plan to announce a photo quiz at some point later this year. The next grand rounds that we're conducting is on August 9th, where Dr. Nada Elbuluk at USC is going to present on pigmentary disorders in skin of color. So we're really pleased to have Dr. Elbuluk presenting in August. And next, and the final slide is residents are graduating. You might not have access to Visual DX after the 31st. There's a promo code called Academy that you can put in on the Visual DX site if you want a license, because you're losing access as you leave your academic site. And last, a final thank you to our sponsor for tonight, Janssen, part of J&J. We appreciate Janssen effort to bring innovation to dermatology. And again, I want to thank this great panel. It's, obviously a passion of ours at Visual DX. And, I think I heard focus, focus, focus as one of the most important issues. We as dermatologists get images on our smartphones from our cousins, from our relatives, from our friends, and they're out of focus. And I know it drives us all nuts that we need, first of all, to have in focus, well-composed images. And with that, thank you.